Hello and welcome to webinar series. Myself Shanti, and today our topic for discussion is all about intravascular ultrasound in percutaneous coronary interventions. And today's expert panelist is none other Dr. Pawan Poddar, who is our director of Cath Lab, senior consultant, interventional cardiologist, and we are very privileged and honored to be with you, sir, today for sharing this platform. I welcome you, sir.
Good afternoon, everyone. So today we have very talented Jestina, who is going to speak about intravascular ultrasound in coronary interventions. And nowadays in Western countries, almost more than 90% of procedures are done with intravascular imaging. IVUS is one of those imaging modalities. In our country, IVUS is still not being done in so many cases, but the numbers are picking up. Most of the centers in big cities, they are doing around 30 to 40% of cases under IVUS guidance. And in future, more and more cases will be done under IVUS guidance. So let us go through the discussion, and then I think once we start the discussion, we will know the utility of IVUS in percutaneous interventions.
Yes.
Okay, so I
Yeah,
invite Jeslina to start her talk, and then
yeah,
we will see the utility of IVUS in most of the percutaneous procedures.
yes, yes, sir. Thank you so much for your warm introduction. And let me also extend my warm welcome to Miss Justina, a nurse from ICU from Malakpet unit. I welcome you, Justina. And yes, as sir said, the usage of IVS is very much known in the Western world, and in India, we are, doing the same. I think, yeah, it is prominent technology which is coming up, and which is already there existing. So, sir, your insight on is IVS the safest and the most effective critical imaging tool for percutaneous coronary interventions procedures? Over to you, sir.
Yeah, the thing is earlier we were used to doing stenting only by angiographic guidance.
Yes, sir.
But since this imaging modalities, intravascular imaging modalities have come into existence, what we have realized that though some cases where angiographic results may be very good, when these patients undergo intravascular imaging by IVUS or OCT, what we found there may be areas where the stent is not well opposed to the vessel. So if
Yes.
those cases are left as such, then later after 3 months, 6 months, these patients can come back with another problem at the same location where the stent is not posed. Some cases, angiographically, the stent appears well expanded. But when we do IVUS or when we do OCT, what we found some areas, the expansion may not be appropriate. Again, these are the cases if we don't tackle that under expansion at the same time, these patients are going to come back again with problem at the same location. So what IVUS and OCT has done is that when we do the procedure under their guidance, it helps us to uh, properly size the stent. We know the length of the stent which we have to use. We know the diameter of the stent which we have to use. And sometimes if the vessel has excess of calcification, that information also we get hand. So if there's an excess of calcification, then we have to use other modalities to deal with the calcium so that our stent expansion is proper. So, and even after deploying the stent, we can again put the IVUS and see whether our result is good or not. If we find that there is some under expansion or some areas which are not opposed, then we can take another high pressure balloon and expand those areas properly. So with all this, I think the long-term results are going to be much better than only with angiography guidance. And I think even safety-wise also sometimes some edge dissections and all we can miss on angiography. Those will be picked up much better with IVUS.
So, sir, you were mentioning about under expansion. Like you mean to say under expansion of stent previously when the patient is done with the stenting, or it is your finding that the lesions are there or sort of kind of abnormalities.
No. I am talking about when we are doing a procedure, stent procedure. So when we deploy the stent, previously we used to check only with angiogram. Angiography sometimes because angiography gives you only two-dimensional image. Some
Yes,
areas may be under expansion, which may not be picked up by angiography. So when we put a IVUS in the same time when we put the stent, after putting the stent, we can be sure about the proper expansion of the stent.
yes,
If the stent is well expanded and all, then we don't have to do another balloon dilatation.
yes.
So if there are some areas of under expansion, what we can do, we can do another balloon dilatation and then again repeat the IVUS. Once we are satisfied with the results, then we can come out.
And that's how we use something called like a cross-sectional images when we
Yeah.
use
IVUS,
this tool.
IVUS
Yeah.
gives you a cross-sectional image with of the vessel actually inside the
Yes.
vessel. So from the distal end, the IVUS catheter gradually moves forward. So the whole area of the stent we can image from inside the vessel. So we can see the cross section. If there are some areas where the stent is not opposed to the vessel wall, or if there are some areas where the expansion is not proper because there's some underlying calcium or something, then we can always do a post dilatation with a high pressure balloon, and we can achieve good expansion of the stent.
So let us learn more about this cutting edge technology. And over to you, Justina, for the rest of the discussion. Yes.
Good afternoon, all. I'm Jestina, and thank you for giving me this opportunity. And I appreciate your trust in me. And IVUS is nowadays it's becoming an integral in coronary intervention. So let's expand our understanding on IVUS. So it's an imaging technology unit that uses a small ultrasound probe inserted into a blood vessel of the heart over guide wire to produce images. It helps visualizes blockages or narrowings, lesions. It guides stenting and provides a real-time high-resolution images from within the BVs, aiding in diagnosis and treatment of cardiovascular conditions.
So, sir, here I would like to again ask you is just go back to the previous slide, Justy. And what do you mean by stent, sir? Like when sorry, the lesions. When we talk about lesion, the lesions are these the substances or calcified deposits or any process in the heart structure, sir?
This lesions, what we mean is these are the blockages within the heart vessels. So the
Yes.
blockages can be composed of different components actually. So
Yes.
in younger patients, what we find it is mostly fatty deposits actually. Most of the time it's the cholesterol which gets deposited. So in the IVUS, we can find out whether it is a fatty plaque or whether it is a fibrous plaque. Fibrous plaque means there's a lot of collagen fibers and all which gets deposited in the vessel wall and which cause the blockage. Sometimes these plaques may be calcified also. There may be calcium deposits also in the plaque. So with IVUS, we can identify these types of blockages. We have plaques, we have fibrofatty plaques where there's a mixture of fibrous and fatty elements. Then we have fibrous plaques, and then we have fibrocalcific plaques, which is a mixture of fibrous and calcific. When we see the calcium, we can also identify whether what is the thickness of the calcium. So if the calcium is very much thick, then we have to use modalities to deal with the calcium also before putting the stent. So we can also identify the circumference of the calcium, whether it occupies 90 degrees, 180 degrees, 270 degrees, or 360 degrees, whole circumference of the vessel. And also we can identify the length of the calcium also. What is the length of the calcium? So all those things help to prepare the lesion properly before putting the stent. We can't directly go and put the stent if there are a lot of calcium. We have to expand with there are different types of balloons which can be used to deal with the calcium. We have cutting balloons, we have intravascular lithotripsy balloons, and sometimes we have another device called rotablation, which drills into the calcium. So if the calcium is very extensive, sometimes we have to use one or more of these modalities. Then we can put the stent, because if we directly try to put the stent is not going to expand because the calcium is like a bone. It is very hard like a
Yes.
bone. And if the calcium stent is not properly expanded, long-term results are not going to be good. The patient may come with restenosis after some time. So IVUS helps to characterize the lesions. It helps to identify the diameter of the vessel beyond the blockage and before the blockage. It helps us to choose the size of the stent which has to be used. Even we can choose the proper length of the stent. We can measure the exact length of the blockage on IVUS. Every millimeter can be measured. So all this information comes by doing IVUS. When we do angiographically, we can get some of this information, but that information is not always very accurate based on angiography. Angiography has its own limitations.
So, sir, you mean to say like IVS first, we perform IVS, and then if required, then and there itself we go for uh, IVS guided angioplasty and like this, sir, vice versa, like,
Yeah, most
or
of the
depends on the
time.
severity of
Yeah.
abnormalities.
Yeah, no, the decision to do the stenting is based on the clinical picture of the patient.
Yes.
Also, some maybe it may be guided by some OPD investigations that we do. Sometimes patient comes with chronic stable angina, we will do the treadmill test, or we can do a nuclear imaging stress test. If these tests are positive and on angiography, if we find more than 70% blockage, then the decision to stent is taken. And IVUS is done to guide that procedure, to know about the composition of the blockage, to decide about the correct size and length of the stent. And once the stenting is done, IVUS is done to confirm whether our result is good or not. The stent expansion, everything is good. There are no edge dissections. There are no areas of malopposition. All this IVUS is done to confirm after the stenting is done. If we find that there is something which is not perfect, then we can always take another balloon, do the balloon dilatation, and then achieve a proper expansion and opposition of the stent. Some cases where the blockage is borderline, particularly in the left main coronary artery, sometimes IVUS is used to decide whether we need to stent this particular blockage or not. Sometimes that minimal luminal area we can calculate by IVUS. So sometimes that minimal luminal area is calculated in the left main, and if it is less than 6, then the decision is taken to stent that particular area. So most of the time it is used to guide the intervention, and sometimes it is used to decide whether to stent or not. It can be used for both the things.
So very interesting. I think, Justina, if the Cath Lab is just nearby, you can just go and see this, technology. It is very interesting as sir is, explaining to us. And I think all of the nurses, sometimes they should take the opportunity by just, be as an observer and how this technology works for patient safety and CV conditions. Yes. Yeah, you would like to talk about these. I think we will only be able to understand from sir about this miniature tool. I think, sir, this is the IVS monitor and these are your guide wires. And this is pull back, something is written. I think this is a kind of a transducer or maybe what is this about, sir? And is this a probe or guide wire or it is a ultrasound probe, I guess.
Yeah, see, the thing is the left-hand side, the image we have is the monitor actually. So here is
Yes.
the monitor and the console actually. So the monitor is where the image will be displayed, and
Yes.
the console has some buttons where we can label our runs, whether it is pre-stenting, post-stenting, which vessel, all this labeling can be done. And even the name of the patient can be entered, and the consultant and all date, time, everything can be entered. And then the image on the center is the IVUS catheter. It is a very, very miniature catheter actually.
Yes.
It goes over a wire which is 0.033 inches. 0.033 inches. It's such a small wire.
Yes.
Okay, it's a very, very small wire, 0.014 inches actually, very, very small wire. So it's a technological marvel actually, you can say. It's such a small thing and it goes inside our vessels which are 2 mm, 3 mm or at the most 3.5, 4 mm. So it goes inside the vessel and it images the vessel from inside. So this IVUS catheter is connected to the third uh, image you are seeing. This is the pullback mechanism. So it has a mechanical pull back actually. It comes back at a fixed speed so that we can measure the length of the vessel. Sometimes we can pull it manually also, but if we pull it manually, we will get the images, but we cannot measure the length of the blockage. If we use this mechanized pull back where the catheter comes back slowly at a speed, we can measure the length of the lesion also. So it can be done with this mechanical pullback also, or sometimes we can use manual pullback also. But the main advantage of mechanical pullback is that we can measure the length of the blockage also. With manual pullback, we will get the images. We can measure the diameters and all, but we cannot measure the length of the blockage.
Yeah, Christine. Sorry, Justina. Yeah.
So now let's know how does this IVUS procedure works. The ultrasound probe emits sound waves and assesses the severity of the blockages, lesions, and calcified plaques.
We have already, just go back. We have already spoken about the plaques and all. And so how does it, the sound waves, how does it use the sound waves to clear the blockages? Like it emits sounds
It
like.
doesn't clear the blockages actually. It gives us an information because the vessel is composed of different materials actually. So these materials, they will observe the sound waves and reflect the sound waves to variable extent. Okay. So there are some components which are composed of, say, smooth muscle cell. So their
Yes.
absorption and reflection of sound waves will be different compared to a tissue which is made up of mostly fat. Similarly, a calcium will do it to a different extent. So what happens, the sound waves which are reflected back, they are assessed by the ultrasound probe which is there at the tip, and the image is created based on the different reflection of this sound waves. So based on that, we get, so here the image, the image will appear. You can see the image in the center, the black and white image. This is how the image of IVUS will appear. Here we have the central round part, radiolucent round part. This is the artery actually. This is the cross sectional of the artery at that particular level.
Yes.
So here there's a very dark uniform dot in the center actually. That is the IVUS probe actually.
Okay,
center में जो एकदम uniform black, jet black is there, no? That is the IVUS probe actually.
Yes.
Surrounding the IVUS probe, again we have a black area, but we have some in between some grayish dot like things. So that is the blood actually. So that is the blood. So that is the lumen of the vessel. Actual lumen of the vessel will be outer yellow line you are seeing, no? That is the lumen of the vessel. But here, in between the outer and the middle yellow line, there is some deposits here. So this is the plaque. This is the plaque. This is the blockage. The lumen has come down. Okay. So this blockage is mostly a fibrous blockage. If it is a fatty blockage, it will be more radiolucent. It will be more black. If it is a fibrous, it is like this. It is a mixture of black and white, grayish type of thing. If it is calcium, it will be more white. It is going to be
this.
Yeah, it is more white. Yeah. So here we have a plug. We have a plug starting around 1 o'clock position, and it is extending till 7 or 8 o'clock position. The plug is mainly fibrous plug. It is a fibrous plug.
Yes. Yes, sir. As you have already mentioned, like we get to see these images like calcified nodule. And IVUS technology measures lesion length, vessel diameter, plaque, and composition made stent optimization as well.
Yeah. This is the main reason why we use IVUS. We get a proper assessment of the plaque composition. We know whether it is a fatty plaque, it is a fibrous plaque, or it is a calcified plaque. And then we also get correct information about the diameter of the stent to be used, the length of the stent to be used. Why this information is important? Because what happens sometimes if it is a very fibrous plaque, the normal balloon may not expand it. Even when we deploy the stent, sometimes the stent may again collapse because of the dense fibrous tissue. So sometimes we have to use a cutting balloon before we deploy the stent. Cutting balloon has some blade-like things on the outer surface. What it does, it cuts through the fibrous tissue. It will cause many incisions in the fibrous tissue. And then when we deploy the stent, our stent expands properly. So this information before is very important, because once we have deployed the stent, then sometimes it is very difficult to expand it, because the fibrous tissue is will not yield to with normal balloon dilatation. And if there's a calcified blockage, then again, as I told, there are a lot of devices which have to be used to manage that calcium. If we don't manage that calcium before putting the stent, our stent is never going to expand properly. And a suboptimal expansion, a patient is invariably going to come back again within 3 to 6 months with the blockage at the same location. So having a knowledge about all this and dealing with the calcium and the fibrous tissue beforehand is very, very important, because angiography sometimes may not give you the correct assessment of the whether the blockage is fibrous or it is fatty. We cannot know by angiographically. Calcium sometimes can be seen angiographically, but that too, sometimes the amount of calcium which we see angiographically and what we see in IVUS, there is a lot of contradictions in that. Sometimes angiographically it appears very mild. When we do IVUS, we find significant calcium. Sometimes angiographically it appears very significant, but when we do IVUS, we don't find that significant luminal calcium. So IVUS helps in that regard.
Yes. And maybe a little very common question we might have, like, what is the procedure duration and route, and whether sedation or contrast is being used for these procedure?
See, the rest of the procedure is same as we do this angiography and angioplasty. The procedure doesn't change. Only the thing is key, the wire use is the same, the balloon use is the same, the stent use is the same. Only before doing the balloon dilatation, we put the IVUS catheter, we get images from inside. And then again, after stenting, we will again put the IVUS catheter inside and get the images. So only the time, it takes a little bit longer time, because maybe 5 or 10 minutes longer than the usual procedure, because we are doing IVUS 2 or 3 times in between the procedure. Otherwise, preparation of the patient, everything is same as a routine angioplasty and stenting procedure. It doesn't change. We can do it through the radial or the femoral as a normal angioplasty. The hardware used, everything is same, except that the IVUS catheter and the console we use, that is different compared to a normal angioplasty and stenting procedure.
Yeah, Jestina. Yeah.
So now I would like to discuss on the pre-procedure follow-up and the care. So this is the most important part for all nurses to know. So first of all, we should obtain the consent. Patient family education is must. Keep the patient on NBM after a light breakfast. Insert a large gauge IV cannula on the left hand. Start IVF. And we have to send the laboratory investigations like pre-angio panel, PT with INR, APTT. Blood grouping is also must. And if there is any deviation or abnormality from the normal range, we should inform to the consultant cardiologist and get an ECG 2D echo done. Assess for allergies, especially to contrast dyes or anesthesia. Prepare the site. Monitor the hemodynamic stability of the and ECG. Shift to Cath Lab on time with all the reports and imaging, and hand over to the Cath Lab system.
So, sir, this is all about our pre-procedure which nurses are supposed to follow. Do you have any other concerns which you would like to just tell, one or two, for related to pre-procedure? What should be our cautions? What we are supposed to take? Anything, any challenging scenarios?
In pre-procedure preparation for IVUS is not different from a routine angioplasty. It is same as routine angioplasty. I think most of the things C has covered. Here, the thing is, we have two imaging modalities. We have IVUS, and then we have another imaging modality called OCT. OCT uses the light waves to give the images. So OCT images are more sharper, but they can't penetrate the vessels deep actually. So we don't get very deep images. OCT may generally we have to use a contrast while we are imaging, because the RBCs and all which are present in the blood, they interfere with the images. So while we are recording the images, we have to push the contrast very hard to clear the blood that surrounding the catheter of RBCs. The contrast will push the RBCs. So the patient who have renal dysfunction, who have high creatinine and all, sometimes we prefer to use IVUS, not use OCT, because OCT we have to use more contrast while doing the OCT. IVUS we don't need. Here, regarding the preparation of the patient, sometimes some patients who have renal dysfunction, they also have a necessity to undergo angiogram. In those patients, actually, we need to take some extra precaution. If the patient's lungs are clear and all, then proper hydration in those patients is important. Nurses can discuss with the consultant and start this patient on normal saline. Sometimes we will add soda bicarbonate to the normal saline and start before the procedure. And sometimes we give them N-acetylcysteine also tablets before the procedure. And we continue them for 2 days after the procedure also to reduce the chances of contrast-induced nephropathy. In such patients, IVUS also has an important role, because sometimes we can do the procedure with a minimal or no contrast using the IVUS. So that is another advantage of doing the IVUS. Routine angioplasty procedure, sometimes we end up using 100-150 ml contrast. But those type of cases, sometimes it is possible to do with IVUS with minimal 10 to 15 ml contrast also. Only while deploying the stent, we give the contrast to visualize the position of the stent. And then one final check angiogram we will do. Rest of everything we will do with IVUS. We will be doing IVUS, and multiple times we will be putting the catheters inside to check the result and all. And we will be using minimal contrast. So that is another advantage. In Western countries and even in our countries, there are a lot of operators who do very complicated procedures in this kidney patients, and they do it under IVUS guidance. Very little contrast they will be using during the procedure.
The next slide discusses on the immediate post-procedural care and education to the patient. If IVUS guided angioplasty or PTCA is done, we have to immediately check the vitals, take an ECG, monitor the vascular site, that is the femoral or the radial site, for signs of bleeding or hematoma. As sir has already discussed on the contrast-induced nephropathy, we have to watch for that, and pain management should be done. Also reassess for the pain, if the patient is having any type of pain or not. And we have to position the patient with caution if the approach is from the femoral site. That is, we have to assist for elementary needs, assist feeding with 30-degree head and elevation, and immobilize the lower limb if the approach is from the femoral site, and tell the client to have a finger compression of finger movements if the approach is from the radial site, and administer the medications timely.
And sir, we expect all the nurses to just, give us information whenever they have these key red flags. Whenever sometimes things goes very uneventful in the ICUs, and I think, and yes, very great that you all teach our nurses that what they should be, the escalating the clinical parameters. So I was trying to understand from Justina, like as we receive the patient, like we should check a distal pulse, and patient may experience sometimes vasovagal reactions, and observe ECG, which is again important, and this life-saving instrument also to be kept ready in case the patient has a potential arrhythmias experience. So any other point, or is it the correct point, sir, what we try to, trying to tell the audience?
Yeah, regarding the post-op care, vasovagals are very common in the post-op period. The vasovagals can result from a lot of causes. One important cause is with regard to pain from the local site. Sometimes the compression bandage is so tight, it causes pain at the compression site, and that can lead to vasovagal reaction. Sometimes if the bladder is distended and the patient is unable to pass urine and all, that can also lead to vasovagal reaction. So how to identify vasovagal reaction? So in all types of hypotension, generally they will be tachycardia. But vasovagal reaction is one where you can have a combination of bradycardia with hypotension. So whenever you have a combination of bradycardia with hypotension, you should always suspect it is a vasovagal reaction. So whenever such a patient comes from the cath lab, you should be aware of how to identify the vasovagal reaction and how to treat the vasovagal reaction. Because once you have a stent placed inside, sometimes if the blood pressure is low for some prolonged time, it can lead to stent thrombosis. It can lead to development of thrombus within the stent, and that could be catastrophic. So these vasovagal reactions need to be identified very early, and they should be managed very quickly. So how you can manage if the patient's LV function and all is good, you should rush in fluid. You should rush in normal saline very fast. And you should have atropine also ready. Sometimes if the bradycardia is significant, you should give 1 cc of atropine IV. And you will see within few seconds or few minutes, all those things, abnormal vitals, they revert back to normal. Low bradycardia comes, you will see it normalizes, or sometimes it overshoots because effect of atropine takes place. Sometimes it goes more than 100. And even the blood pressure, which was dropping, it starts stabilizing. So all those things are very, very important, but you should identify it quickly and should manage it quickly. Regarding the radial access site also, if the bandage is very tight, sometimes patient can develop redness and swellings of the fingers and all. Sometimes they can develop cyanosis of the fingers. So once the patient comes, you should try to put the pulse oximeter on all the fingers and see whether there's a good graph and whether it is showing the oxygen saturation or not. So if there's a good graph and there's a oxygen saturation is good, that means that the perfusion to the fingers, all the fingers is good. And you should check all the fingers because only the inner half is supplied by the ulnar and the outer half is supplied by the radial. So you should check all the fingers. Sometimes if you check only the little finger which is supplied by the ulnar, you may miss if there's a very tight compression of the radial artery and the supply to the thumb, index and middle finger may get affected. So you should check on all the fingers.
So very valid points, sir. Like you have told us how to treat, not only looking at the signs of vasovagal, even treatment is important, like rushing the fluid and atropine, keeping the once is atropine ready. I will try to correct the slide and send to Justina so that everybody can, yeah, go through. Yes. And we are just coming towards the end of the discussion. Benefits, as you have already discussed, that diagnosis and it guides the treatment and monitoring. And like, sir, if the patient undergoes IVUS and then is there any again recurrence or reoccurrence of this condition again? Patient has the potentiality of coming back to you that yes, it is not done, or what is your insight on the same, sir?
Yeah, this stenting procedure, definitely 5% recurrence rates are there, even when we use the best of stents, even if we do under imaging guidance. So recurrences will be there, but when we do IVUS guided procedures, the recurrences or restenosis will be less compared to when we do only angiography guided procedures. So it will not become 0% because there are some inherent factors related to the stent also. So restenosis sometimes is because of overgrowth of tissues within the stent. So IVUS can only optimize the procedure and it will result in some reduction in restenosis procedure. It cannot make it 0%. Okay.
Yes. So, discharge tips, what we always provide by your end to all our patients. I think we have tried quoting all the points and avoid heavy lifting if radial access is used and femoral. I think these are the core fundamental cautions which anybody should use. Yes, sir. And yes, a final conclusion note from your end, and then we end the session, sir.
Yeah, the IVUS and OCT, there are intravascular imaging modalities. Most of the guidelines now, the American Heart Association or the European Society of Cardiology, they recommend most of the procedures we should do under these imaging modalities because it guides the procedure in a much better way. They help us to choose the correct size, length of the stent to be used. And regarding the pre-stenting preparation of the lesion also. This procedures, this imaging modalities help us to decide what type of balloon or what type of calcium modifying device we should use in a particular case. And even after deployment of the stent also, these imaging modalities help us to assess our result, whether the stent expansion, stent apposition is proper, whether there is a edge dissection or not. So all those information which we cannot get with plain angiography, we can get with IVUS. And in future, I think because this imaging modalities are not so expensive, more and more cases will be done under this imaging modalities as in the Western world. And this imaging modalities definitely they have reduced the recurrence of the lesions compared to procedure being done under plain angiography. Okay.
Very interesting, discussion it was, though the time is not sufficient and we are just learning right from IVL now today, IVUS, and then you have mentioned about OCT also. We may connect for the OCT as well. And thank you, sir, for your very valid and very, productive discussion and for your time. I thank Justina also. She helped me in guiding and preparing the PPT. And yes, we like to request all the audiences, please connect with our www.yashodahospitals.com website, where our expertise like doctors are those who always provide the health talks in a form of, awareness and learning for everyone. Thank you, sir. Thank you, Justina.
Thank you for having me.
Thank you, sir.